Okay.
Hello, everyone. We'll just give uh, 1 more 2 minutes for some other people to join. Good afternoon, everybody. My name is Raul Ulises Hernandez Ramirez, and I'm a research scientist at Yale School of Public Health and the Center for Medicine Implementation and Prevention Science, and I direct the Dissemination Implementation Science Methods core of the Center for Interdisciplinary Research on AIDS, CIRA. Thank you for joining us for today's webinar. This webinar is co-sponsored by the DSM core and the Ready Hub, which stands for the Rigorous, Rapid, and Relevant Evidence Adaptation and Implementation to Ending the HIV Epidemic, and the Center for Methods Implementation and Prevention Science, CIMIPS. The DSM core provides expertise and methodological consultation, technical assistance, grants peer review, trainings, and seminars, participate in developing and applying innovative research methods, and assess zero impact. The Radio Hub provides technical assistance to ending the HIV epidemic projects and other HIV researchers and implementers, and collaborates with a network of hubs across the country with the goal of creating opportunities to translate local knowledge into generalizable knowledge whenever possible. CMIPS develops and disseminates innovative methodological approaches to address implementation gaps and directly improve health outcomes. Our speaker today is David Oliveros, who is going to talk about the nominal group technique and how he has used it and what he has found in some of his HIV research work. David is Associate Director for International Research in the section of infectious diseases of the Department of Internal Medicine at the Yale School of Medicine, and he oversees multi-country NIH-funded studies focused on stigma reduction, integrated care models for HIV and substance use. His research focuses on strategies to optimize the care continuums for HIV as well as for opioid use disorder, particularly across Latin America, Southeast Asia, Eastern Europe, and Central Asia. He uses mixed methods and implementation science approaches to identify service gaps and strengthen care delivery for key populations. I welcome David, who is going to talk about leveraging nominal group technique to identify priorities in HIV prevention and care, lessons from Peru and Malaysia.
Hello, everyone, and thank you so much, Raul, for the introduction and for sharing your space for me to share my work with you all. So as Raul mentioned, today I'm going to be focusing on nominal group technique and its application to HIV research, sharing some insights that we have learned from our projects in Peru and Malaysia. But before we start, I just wanted to share a little about me. So I graduated here from Yale from the MPH program in 2023. And when I was at Yale, I mostly focused on LGBTQ health disparities and inequities, And that led me to the world of HIV and substance use epidemiology, which later transitioned into the world of implementation science. So I've been working here at the Department of Internal Medicine for the last 3 years now. And as Raul mentioned, my work mostly focused on identifying gaps in the substance use and HIV care continuums in uh, international settings in Peru, Malaysia, Central Asia, and Eastern Europe. Um, and when I was at Yale, I did my research in Peru, and I have had the privilege of continuing working there for the last 4 years, which has been a tremendous joy. So here I am with my teams from Peru and Malaysia. But today I'll be focusing on nominal group technique, which is a technique that we use a lot in the Altice lab for our research projects. We virtually use them for all of our research projects as like a pre-implementation assessment or as a way to understand the context in which we're working in. So nominal group technique is a structured mixed methods tool that was created by Delvig, Van de Ven, and Gustafsson, who are also the creators of other consensus-based methods, such as the Delphi method, which is a survey-based tool that creates several rounds of surveys to generate a consensus between different experts about a specific topic. Uh, and I want to emphasize that while I'll be talking about nominal group technique as a research tool and a research method, this tool is actually grounded in social psychology and organizational science. So it's a tool that was developed in organizational settings to understand how do we improve decision making and how do we improve group-based decision making. So ultimately, the overarching goal of nominal group technique is to generate consensus on different actions or elements that need to be prioritized. So nominal group technique has been growing from that into a research method that we have been using to understand implementation landscapes and to inform many of our research projects around the world. So I'll be going through the procedures of the NGT, and then I'll have an opportunity to share some of the insights that we have learned from our projects in Peru and Malaysia. So there are four main steps in nominal group technique, and those consist of first, there's a very specific question that is posed. Normally, we focus our NGTs on barriers and facilitators, but they could be really focused on a wide range of topics. So after you pose that question, there's a period of silent idea generation in which you allow participants to individually, very importantly, write down their ideas. And this could be either in a piece of paper or in their phones, somewhere where they can like record all of their ideas that are elicited after this specific question. And then there's a period of round robin feedback and the recording of these ideas. It could be either on a whiteboard or a flip chart or like an Excel spreadsheet. But essentially, you want to go through all the room and you want to get an idea from each person until basically there's saturation of ideas and no one else has anything else to contribute. And that ensures that there is equal input from all participants in the room. So as opposed to other forms of focus groups, I have to emphasize that this is a technique that we use in focus groups. It's a little more structured in the way that you want one idea or one comment or one contribution from every person. And to prevent someone from dominating the conversation, you're going to want to manage the room in a way that you get one idea from every person until essentially there's no additional ideas. And then the facilitator or the main person in charge of this focus group writes down these ideas without giving them any judgment or appreciation of the idea. And then there's a period in which you have a chance of discussion, limited discussion, and a clarification of ideas. So sometimes it happens that there's one or two ideas that are too similar, or that maybe you want the participants' inputs in order to like condense certain ideas or clarify an idea. So there's an opportunity to do that. And finally, there's an opportunity for participants to vote on the ideas that they consider to be the most important or those of highest priority. So normally we like to give participants 3 votes, and they're able to allocate those 3 votes across ideas however they think best. So if they think, for example, one idea is the most important, then they're able to allocate all the votes for one idea, or they're also able to distribute their votes across different ideas, depending on whatever they see best. So I know this might be a little abstract, but I think once we get into the actual topics, research topics, I think it'll start to make a little more sense. And as I mentioned, the final goal is to generate some sort of consensus or group decision making as to what ideas are the most important according to the group. So in terms of what you would need for nominal group technique, it's actually very simple. You need a primary facilitator who's going to guide the conversation and the discussion. And then ideally, you also want to have a note taker who is able to note different aspects of the conversation. Maybe you have someone who's like writing down quotes, or you have someone who's uh, just in general like a second opinion in the conversation, but the primary facilitator is the person who's going to be in charge of noting down the ideas. And as I mentioned earlier, that could be in a flip chart or a whiteboard or on an Excel spreadsheet. We've actually done quite a bit of focus groups online, and I think they have worked pretty well. So that's always an option. I think it's especially useful if you have like a sensitive topic, or there's a group of participants who really don't want to show their face. I think giving them the opportunity to just change their display name or hide their video, I think allows for like a more anonymous, confidential discussion. I think 6 to 12 participants is probably the ideal for a nominal group technique focus group. I think less than that, you don't really get a lot of information. Maybe you don't reach saturation of ideas. And I think when it gets to more than 12, it just starts becoming like a little unmanageable and a little hard to do. And I think audio recording, of course, if you're authorized to do that, if you have IRB authorization to do that, I think is great because you get to kind of like capture participants' own voices in the conversation, and then you are able to analyze that like you would any other like uh, qualitative interview transcript or other forms of qualitative research. So in terms of the advantages of NGT, I think the fact that they're rapid and easy to implement. So normally when we do NGT, we like to focus on, as I mentioned, on barriers and facilitators. And sometimes that can take maybe like an hour and a half. But I think these are focus groups that can be easily done in like 20 minutes. And as I was mentioning earlier, I think you have to focus exclusively on research to do a nominal group technique in some of our projects that we work in, and I'll touch base upon this later, but we really encourage people to use this technique in order to just kind of like reach consensus or to elicit certain ideas that might not easily come up in other settings, or if you're not doing a discussion in a group. So I think this is probably one of the advantages of nominal group technique. And unlike other forms of qualitative research, I think, for example, doing like semi-structured interviews can be quite laborious, especially in terms of like the transcription and the analysis. And I think the advantage of nominal group technique is that you're able to get quite a substantial amount of information in a relatively short amount of time. As I was mentioning earlier, it also promotes group decision making. It encourages creativity and individual thinking because every person gets empowered to contribute their own individual ideas. Um, and I also think it helps to minimize hierarchies and groupthink. I think we work in a lot of settings where sometimes you have like the head doctor or someone who has like a really high status or a high position, and normally those are the voices that are valued and prioritized. But in NGT, everyone votes counts the same, and people are encouraged to contribute and are encouraged to come up with solutions and contribute to the conversation. Um, it also provides qualitative and quantitative data. So it has a way of, so you get like a rank ordered list of ideas. So you get numbers and you get percentages, but you also get very rich quotes and very rich ideas that you're able to analyze later. You also get a large number of ideas. Sometimes we've had NGTs where we're focusing on barriers and we have like 15, 20 barriers that come up that maybe would have been a little harder to come up if we were doing just like a semi-structured interview. And for all these reasons, I think this method is excellent to identify barriers and facilitators, which make it very action-oriented. You leave the room, you leave the conversation with a general direction or of where you want to go and where the group wants to go in terms of like possible barriers or solutions that have been identified. So for these reasons, NGT is great for implementation research because it really lets you identify what's the gap between like what we call the no-do gap. What's really preventing us from implementing like a very specific policy or intervention, and what can we do about it next? So for this reason, I think I really encourage the use of NGT for any type of like pre-implementation research or preliminary research. I think it's great. It's something that you can easily do, for example, for like a grant application or if you are thinking of kind of like a larger project and you're not sure which direction to go, I think it's excellent to just kind of like help you establish that path and that direction. And for like also for like grant reviewers or reviewers in general, like they see that you have kind of like some sort of preliminary research that supports, I don't know, like the intervention that you want to do or the solution that you want to implement. I think NGT is great in that sense. Some caveats or things to keep in mind about NGTs is that, like other forms of qualitative research, they're not intended to generate what I would call generalizable knowledge. In other words, they're very like context and moment bound. So if you're doing, for example, an NGT at a specific clinic or a specific location, you have to understand that the results from that NGT are going to be specific to that place, and that perhaps the barriers that you identify to a certain intervention in that place are going to be very different from the barriers from another clinic. So just something to keep in mind as you conduct these focus groups. It's also very sensitive to group composition. So obviously the results that you get to be dependent on who's in the group and who's recruited that day and who's invited to participate. So that might also create like a certain like selection bias. So you want to make sure that you have like representation from a lot of different people and members of that stakeholder group. Um, the results are not attributed to a single individual. In other words, like the results that you get at the end are just like a group consensus. Um, of course, it also, as I was mentioning, it helps minimize certain power dynamics and it helps that someone is not dominating the conversation, but it's not gonna like eliminate that entirely. So that also requires like skilled facilitation and practice in order to be able to kind of like manage those dynamics and hierarchies. And I think importantly as well, the results that you get from an NDT are not going to be necessarily like realities, but they're going to be the people's perception of reality. And that's just something to keep in mind. But at the end of the day, these perceptions that people have are also um, quite important to know about. So there's still like important findings, and you just have to be kind of like careful in the way that you present those findings. So before I go into the examples that I have from Peru and Malaysia, I just wanted to see if there's any questions that people from the audience might have. Feel free to like speak up, or if you have any question that you can share in the chat, um, I'm happy to answer them. Yeah, I see there's one question from Archon.
Hi, David. So just to quickly introduce myself, I was a postdoc for Dr. Altice a decade ago. I'm an associate professor, and it's nice to meet you. He's told me a lot about you. So I'm a quantitative scholar, so I have limited knowledge about qualitative, but Rick has been advocating NGT for several years now, so I do appreciate your detailed presentation. So I guess my question has to do about the appropriateness of NGT versus other qualitative methodologies, let's say a semi-structured focus group. So I understand that the structure is what makes it unique, right? That the fact that you can actually sort of engage in group ideation, right? Which is really useful for generating components of an intervention, for maybe creating components or features of, say, like a new app. But based on your experience, when is NGT not appropriate, right? So for example, I'm thinking, if you were to be exploring a group of, underserved, communities or individuals, and you're talking to them about their stigma experiences and perceptions towards the healthcare provider, I'm assuming that NGT would not be as appropriate. But I'm sort of trying to wrap my head around it. So if you could sort of provide some clarification, I would be grateful.
Yeah, of course. I think nice to meet you, Arch, and I think we've corresponded before, but I had never met you virtually. But I think that's a great question, and I think there's certainly like a lot of situations in which NGT is certainly not appropriate. And I think what you mentioned is like a very good example because if you're, for example, trying to understand mechanistically maybe how stigma is manifested in a specific setting or somewhere else, I think that might require you to have like a slightly more exploratory or like in-depth approach. And I think in that situation, it certainly warrants like a structured individual interview. I think NGT is very useful for like these sort of kind of like pre-implementation assessments where you want to have kind of like a large number of ideas or kind of like different directions on where to go. But yeah, I think it's not very appropriate as a research method if you can kind of like want to understand like certain mechanisms, or if you want to like delve deeper into like a specific topic. So stigma is something that has come up a lot in our NGTs, and that I'm gonna have a chance to talk a lot more about that. But I think if you, for example, you could, if you were to identify that stigma is a big problem at X or Y clinic, then you did an NGT on that and you identified that. And then I think if you want to like delve deeper into those issues, and I think then a semi-structured interview might be more appropriate, because you already have kind of like a clear direction or idea of where to go. And now you can like delve deeper into that specific topic. So I think NGT can certainly be like exploratory, but if you want to like delve deeper into those mechanisms and how things manifest like a specific topic, then it might not be as useful. And I think I saw another question from Victor.
Yeah, hello, David. Can you hear me?
Yes, I can hear you.
Okay, my name is Victor Ikechukwuka, and I'm an implementation scientist from Nigeria. I work with the Center for Translation and Implementation Research here in Nigeria, and I was opportune to hear about the NGT technique in our Nigeria Implementation Science Conference that held in 2025. So I would like to ask you this question. Are there certain criteria to be used for the selection of participants for the nominal group? How do we ensure that the group represents the key perspective across, whatever we are trying to study? In your case, HIV prevention and care. So what are the criteria for selecting participants for the NGT?
Yeah, I think that's a really great question. Nice to meet you, Victor. I think what we have found to be useful is to try to do like different focus groups for different stakeholder groups. So you'll see from my examples that whenever we do NGT focus groups, we try to like separate, for example, like patients and providers, just because I think if you were to mix the two, that potentially creates like social desirability or like a power dynamic in which patients might not feel comfortable like speaking about their care or different aspects of their satisfaction with their care or other things that might be sensitive, and that might kind of like hinder the quality of the data that you get. In terms of like sampling, what we usually like to do is like a purposive sampling where we have kind of like an idea of who we want to recruit, and we go to like a certain clinic and recruit. Obviously, that has like its limitations, because if you're, for example, trying to understand, I don't know, barriers to staying in care, and then you do an NGT with everyone who's at the clinic, well, those people are certainly going to experience maybe less barriers than someone who has dropped out of care. So I think that's why it's important to try to kind of like understand, do different NGT focus groups with different groups of people. So for example, last year we did some focus groups on PrEP in Peru, PrEP implementation, and we try to do different focus groups with people who were interested in PrEP, people who were not interested in PrEP, and then also people who are have taken before but are not currently taking. So just doing those three separate focus groups gave us kind of like a wide range of different barriers, and just kind of like lets you understand like this implementation landscape in a way that is a little more complete. And I think there's always going to be kind of like limitations with your sampling. So for example, I'm going to talk about these focus groups that we did in Malaysia with people who inject drugs. And those groups, essentially everyone who participated in those groups were men, of the people who inject drugs. But I also think that, and that's certainly kind of like a limitation that we talked about in our discussion and in our manuscript, that I think that's just kind of like a general limitation of, for example, research on people who use drugs, that especially women face higher barriers to care. And a lot of times they're going to be excluded from research, or they're not going to be represented in the same way as men. So you do want to be careful with who you select to be part of those groups, and how you invite people. I think that's a very important consideration, both in your like while you're doing the focus group, and then of course in like your analysis and your reporting of those results. But I think that's a great question. So now moving on to our first case study of the day. So I'm going to be talking about the decentralization of HIV care in Lima, Peru, and how we have used nominal group technique to inform the work that we do there. So the question is, why decentralize HIV care? Decentralizing HIV care is an evidence-based strategy that is recommended by the World Health Organization and other international organizations to increase healthcare access. And it basically consists of shifting the majority of HIV care from specialty hospitals to primary health centers. So in other words, it's just a matter of integrating HIV care into primary care. And this system improves the efficiency of care because it reduces the burden on specialty providers, and it is also associated with an improvement of different health outcomes. So it improves retention in care, it reduces mortality, it increases ART coverage, and it leads to higher rates of viral suppression. And I might also add, it also serves to destigmatize HIV and reduce stigma towards HIV, because once you integrate it into primary healthcare, that kind of like gives a certain message about HIV that is just kind of like part of routine care as opposed to something that should be treated in like a specialty hospital. And I think Peru is a very good example of that. I'll get to that in a minute. But this is here we have kind of like a hub, what we would call like a hub a spoke model, in which perhaps you have like a specialty hospital for those cases that are really complex, older adults who are living with HIV, who maybe have like different comorbidities. But in general, you can create a network in which you transfer most of your patients, especially those who are stable, to primary healthcare, where they can be seen by not necessarily a specialist, but in many settings, they're even seen just by a nurse or by someone who doesn't have like specialty training in HIV. So in Peru, HIV care is free, antiretroviral therapy is free, but it has historically been concentrated in Lima and in large specialty hospitals. So these hospitals are enormous, and they see anywhere from 3,000 to 6,000 patients. So here we see a map of Lima. Might be a little hard to see, but the dots here are the main ART hospitals in Lima. And then since 2020, in part in response to the pandemic and the challenges that came with the COVID-19 pandemic, Peru was one of the countries that was hit the hardest by the pandemic, and it had the highest mortality rate. So the government started to think how we can like start decentralizing different forms of care, among them HIV care. So the country has been slowly shifting some of that HIV care into smaller primary healthcare facilities, which are these other smaller dots, or some of them are triangles because that means that they have started to provide ART care. But in generally, the system is one that places substantial time, transportation, and economic demands on patients to receive care, because most of the time patients have to go to a facility that's really far away from their home or where they work in order to receive care. So unfortunately, that leads to quite a large implementation gap. So this is the HIV cascade in Peru, where we have all the people who are living with HIV. So Peru actually does a pretty good job at diagnosing people with HIV. Over 92% of people estimated to live with HIV have a diagnosis. But then as we going down the cascade, people start falling out of care. So about 81% of people are linked to care. That means that they're linked to ART and are receiving they're linked to a place where they can then start ART. But unfortunately, this is the biggest implementation gap between those who are linked to care and retaining care. So almost 33% drop between those two steps of the cascade. And that unfortunately also leads to Peru lagging in terms of the percentage of people who are virally suppressed. So these suboptimal levels of retention and care and viral suppression ultimately led, as I was mentioning earlier, in 2020, the Peruvian Ministry of Health recommended to decentralize HIV treatment. And so as part of an R1 study, a step-witch trial that we called VIDA, which has been going on since 2023, we are conducting two implementation strategies in order to support this decentralization process. One of them consists of EcoVida sessions, which are these bi-weekly telementoring sessions between providers of specialty hospitals or doctors with like specialty training and providers from primary healthcare center who don't have that much experience providing HIV care. So what happens in these sessions is that usually there's a didactic presentation in which the doctors present, the faculty of these sessions present on different topics related to HIV care. And there's also usually a case presentation. Participants from the primary healthcare sites are welcome to present cases or to submit questions. So in general, the overarching goal of these sessions is to increase the clinical confidence of these providers who don't have much experience in managing HIV to receive these patients that are being transferred from specialty hospitals. And the other implementation strategy is NIH, which stands for the Network for the Improvement of Addiction Treatment. And this is the first project in which NIH has been used specifically for HIV care. But NIH consists of different implementation tools that are meant to focus on organizational coaching and process improvement. So in general, improving or reducing wait times, improving show-up rates, increasing retention and care. So in Peru, we have what we call rapid cycle testing. So we form these change teams in all these primary healthcare sites and in the specialty hospitals as well. And providers are encouraged to make small, gradual changes in their workflow or the way that they work in order to essentially improve processes. And they receive monthly organizational coaching from one of our 3 dedicated coaches in Peru who visit them every month. And it's very data driven. So we like to collect baseline data in terms of different metrics, like the ones I mentioned, like wait time, or different processes in general, and they get coached and they start setting goals in order to move towards this goal, which is to neutralize HIV care. So as I was mentioning, the overarching goals of these 2 strategies are to improve clinical confidence, improve processes, which is a big issue in Peru, and then also strengthen these hub and spoke models that I was mentioning, where there's bi-directional communication between the specialty hospitals and the primary health centers, which is something that wasn't really quite established before we started doing this project. And I think one of the long-lasting impacts of this project is that we started creating kind of like networks in which the physicians from the primary healthcare sites speak to the physicians and the nurses from the hospitals as well, and they start getting more experience in the management of HIV. So this is just a picture from one of the NIH learning collaboratives that we conduct twice a year in Peru. So we invite members from the different change teams of both the hospitals and the primary healthcare sites to present updates and to present data about their different change projects. And then I want to acknowledge, of course, Rick Altice, the PI, and also Dr. Lynn Madden, who might be here during this meeting, who is our lead NIH implementer, a world expert on NIH. So she's been kind of like leading the charge in implementing these process improvement and organizational coaching measures in Peru. In terms of the methods for our project, so this is one of the first aims of our project before we actually started doing this ongoing work. But we were interested in understanding this implementation landscape, and we were guided by the RE-AIM implementation framework. So we focused on the inner context of RE-AIM, which is essentially the people who are receiving or giving the intervention. And in this case, the intervention is decentralizing HIV care. So we wanted to understand how are people thinking about decentralization, and how are people thinking about this relationship between the hospitals and the primary healthcare centers. So we conducted 6 focus groups using Nominal Group Technique. One of them was with people with HIV who were receiving ART at a hospital in downtown Lima. Another group of people with HIV who were transferred to a primary healthcare site from a specialty hospital. And then 4 groups of healthcare providers. So we had 1 group of healthcare providers from a hospital in downtown Lima, and then 3 mixed groups consisting of staff from the specialty healthcare centers and the primary healthcare centers who were recruited at one of these implementation workshops that we do in Peru. And then, as I was mentioning, NGT always involves a specific question. So the question in this case was, what gets in the way of transferring a patient with HIV from a specialty hospital to a primary health center? And then, as always, we did round robin feedback until there was idea saturation. And then each participant received 3 votes in order to generate a rank order list of ideas. This is just a map of Lima Norte, which is one of the districts that actually has made the most progress in terms of the decentralization of HIV care. These focus groups that I'm going to talk about, we focused on Lima Centro or downtown Lima. So to my earlier point, I think if you were to do different focus groups in different parts of the city, you would get very different results. This is something that we have seen to a certain extent when we have done our collaboratives, because we always like to do new focus groups and kind of try to continuously and iteratively understand the implementation landscape. But in general, I think we have found that there's some difference, but there's also like certain common themes and similarities across all the groups that we have done these focus groups with. And then this is just the raw data that we obtained from these focus groups. These are the ones that we did with patients. I don't have space to show all the barriers that were elicited during these conversations. These were just like the top ranked barriers. So we see here that this is something that, again, we did in like an hour and a half, and we were able to get a lot of very rich information. So in terms of the top ranked barriers, we see that there's some issues in terms of infrastructure or perceptions about a lack of proper infrastructure at the primary healthcare centers in order to for these centers to manage the HIV care of these patients. We see a perception that there is no ART availability at PHCs, but I think overwhelmingly so, we saw that there was across both groups concerns about stigma was one of the things that came out the most. And this has to do with the fact that primary health centers, as I was mentioning earlier, are usually close to patients' homes. So if people are to receive care there, they might run into their neighborhoods or their families. So there's that concern that if they were to receive HIV care at those centers, then they have concerns about confidentiality and who's going to see them. And perhaps there's not like proper privacy at these places, or perhaps they're going to be stigmatized by the healthcare staff there. So these are concerns that we saw across the board from both groups of patients. And to my earlier point about the fact that like the results that you get in NGTs are just exceptions, they're not necessarily realities. The patients who were like established in HIV care at the hospitals, they thought that like issues of infrastructure or ART availability, these kind of like structural level issues, they thought that those were big concerns at primary healthcare centers. But when we did those focus groups with the people who were already receiving care at a primary health center, you see that that's not like an issue that came up. That was not like a highly ranked issue for them at all. So this is just kind of like a perfect example of how there's by doing focus groups with different stakeholder groups and people with different characteristics, you start kind of like seeing the difference in those perception of what's considered a barrier. Because these patients, for example, usually prioritize issues relating to individual level support. So like adapting to a new health center or the transfer process itself. They didn't think that infrastructure or ART availability was a big issue for them at all. I think both groups mentioned like a certain level of concern about the expertise of providers at these primary health centers. When I go to look at the results from the healthcare providers, these are the 4 groups of healthcare providers, you see that was a more pronounced issue for them than for the patients. So providers in general were much more concerned than patients about the expertise, the clinical expertise of the people who are going to treat them at these primary health centers. So that's just kind of like a difference that we saw across these stakeholder groups. But again, similar to the patient group, we did see across the board a lot of concerns about stigma and discrimination, both in terms of like stigma from the healthcare staff and then just an issue of like anticipated stigma of feeling that patients were going to be mistreated or they're going to have their status disclosed at these primary health centers because they're smaller or because they don't have enough privacy for many different reasons. This is just a way that we classified a lot of the barriers that came up during the discussion, which is using the socio-ecological model. So we classified the different barriers at the individual, interpersonal, organizational, community, and policy levels. And this is something that you do after the NGT. So with the NGTs, you get like a rank order list of ideas. And then later on, you can start kind of like condensing these ideas into different categories. And then trying to like think about how they relate to each other, how you're going to intervene to address these barriers. And then this is just a summary of all the different barriers that came up and the way that we categorize them. So to my earlier point, we did see that stigma overwhelmingly came up as the top ranked barrier, especially among patients. And then after stigma, we did see that there was a lack of confidence in the clinical expertise at primary health centers, which was especially pronounced for providers. And then we had some other issues such as system level or transfer logistic barriers, such as like processing of documentation or the general transfer process that also came up. Patients were particularly concerned about like a lack of like patient level support. So like finding appointments at these centers or just in general that they didn't feel supported in that decentralization process. But I think pretty overwhelmingly, we saw that stigma was kind of like the top ranked barrier. In terms of like things that came up out of these NGTs, we found that like decentralization remains underscaled due to major barriers related to multi-level HIV stigma and a perceived lack of confidence of the expertise of primary care. And in response to these barriers, we recommend, as we're doing now, implementing tailored organizational coaching for process improvement to address these implementation gaps and stigma reinforcing processes, strengthen the hub and spoke networks of referral, develop clear guidelines and tools for decentralization, such as like a transform or some other tool that really allows you to overcome some of these barriers that came up during the discussion. And then also implement education modules such as Project ECHO to strengthen the confidence in HIV management from these primary care physicians. And I also want to say that a lot of this data that we gathered and that we found through these focus groups was eventually used for grant application. So I'm happy to say that we are likely going to receive a new R01 grant that is going to allow us to focus on stigma reduction among MSM, and I think these focus groups really kind of like provided some like actionable guidance and input on how to implement that in the future. And then I have a copy here of the manuscript. I am including a QR code in case anyone's interested in reading it, but of course, to delve deeper into what we found through these focus groups in Peru. And now before I jump into Malaysia, I wanted to see if maybe there are any questions specific to this work that we have been doing in Peru. So feel free to write something in the chat or raise your hand or speak up if you have questions. I see. Okay. I don't see any questions for now, so I'm just gonna continue with presenting the work for Malaysia, and then maybe at the end we'll have some more time for questions. So another project that we use, Nominal Group Technique, is our current project in Malaysia, in which we're piloting and implementing rapid start ART protocol as a stigma reducing strategy. So before we even started making this protocol and thinking about how we're going to implement this project, we wanted to understand the implementation landscape, and which we wanted to see what are the major barriers for rapid start ART in Kuala Lumpur specifically. So rapid start ART is defined as initiating ART as soon as possible, ideally on the same day of diagnosis or re-engagement with care. And like the decentralization of HIV care, this is an evidence-based strategy that is recommended by the WHO and the International AIDS Society and different national and international organizations to improve HIV care. It is a central feature of the test and treat strategy, and it has been shown to reduce disengagement and time to viral suppression, which in turn also reduces mortality, it reduces HIV transmission, and it also reduces morbidity from opportunistic infections. So rapid start ART is recommended by the Malaysian consensus guidelines, like it is recommended by many national guidelines across the world that recommend rapid, timely initiation. But in practice, this is not what happens on the ground. So unfortunately, in Malaysia and in many other countries, there are high levels of structural and interpersonal stigma towards key populations, including men who have sex with men and people who inject drugs. And these are mostly driven by, I want to say, the criminalization of, for example, in Malaysia, it has to do with the criminalization of same-sex relationships and also the criminalization of people who use drugs. So these forms of stigma ultimately manifest in delays in ART initiation. So in Malaysia, historically, HIV has been concentrated in people who inject drugs. Most recently, there has been an epidemiologic shift, and the MSM are now the group that's most affected by HIV, but historically, people who inject drugs have been the group with the highest prevalence. So the way that this form of stigma manifests towards these key populations is that physicians in Malaysia often do this thing called pill training, in which essentially they give vitamins or placebo pills to the patients, especially those who are perceived as irresponsible or who are perceived to not be possibly adherent to this medication, as a way for them to prove their ability to adhere to treatment or adhere to medication. So it's often born out of providers' own biases and attitudes towards different groups. And this ultimately contributes to delay in ART initiation. So there was this one retrospective study from Kelantan, which is a fairly conservative state in the north of Malaysia, north of peninsular Malaysia. And they found out that the median time to ART initiation for people who inject drugs, especially those who are on methadone, was 3.5 months. So from diagnosis to AT, on average or median was 3.5 months, which is very concerning because this is a period of time in which these patients are going to get could potentially get a lot worse, and they could also transmit HIV to other people, given that they're not going to be virally suppressed. And to support this idea, this is also a study that was done by Rick and team in Malaysia back in 2017, in which they did essentially an experiment in which they presented these hypothetical scenarios to different physicians to see whether or not they would do pill training, or in other words, whether or not they would withhold HIV treatment from these patients. And so, as you can see from these curves, well, also depending on their different CD4 level counts, but mostly depending on who they were more likely to delay treatment for people who inject drugs, people who use alcohol, people who had been formerly incarcerated, people who lived alone, people on methadone, and so forth. But now imagine if you have many of these identities, then you're gonna likely be perceived as someone who's not gonna be adherent to medication and someone who's not gonna be given timely access to medication. So this is something that we knew before going into the study, but we wanted to find out more about this implementation landscape. So in Peru, we went out to do some focus groups. And in this case, our question was, what gets in the way of starting ART on the same day a person with who inject drugs gets diagnosed with HIV? And we did 3 focus groups, or actually I should say 4 focus groups, one with people who inject drugs who are receiving ART at a primary healthcare site, another focus group with community healthcare workers, and then 2 groups of HIV specialists. And then first I'm going to go over some of the quotes that were elicited during these discussions, because this one we actually did record, so we did have transcripts and qualitative data to support some of this rank order data from the NGTs. So this is a quote from a person who injects drugs, who basically says, "The healthcare staff at the primary care clinics are so stingy even when they need to touch us. The stigma is too high. It is as if we are so dirty. That's why people do not want to seek treatment. It's absurd. We feel offended when they show that they are reluctant to touch us. We are human too." So essentially, this participant is emphasizing the stigma that they perceive at the primary healthcare clinic, and even goes to call the healthcare staff stingy. So potentially hinting at the fact that they might not want to use resources or medication on these populations. And then this is a quote from an HIV specialist. What happened in Malaysia is that people who inject drugs are subjected to pill training prior to starting ART. And many will agree that this is still a common practice in Malaysia before starting ART, because we want the patient to get confident in terms of compliance. So again, kind of reinforcing something that we already knew from Malaysia, that people who are perceived to not be compliant are going to be subjected to this period of pill training, are going to withheld treatment until basically the provider wants to give them treatment. And then finally, we did have some quotes from the community healthcare workers. I'm actually not going to read through all of them because I don't think we have much time, but basically emphasizing that the process in order to get ART is very complex, and that there needs to be something to be addressed with these processes. There's issues with laboratory testing, confirmatory testing, and that these are some of the main barriers that they have perceived to be the main barriers to same-day ART or rapid start ART. These are the top ranked barriers that came out of these focus group discussions with the 4 groups. I think once you have all of them in the table, it's actually very nice to visualize and to see how they're similar or different. So I think what struck us the most about these results is that there's quite a dissonance between the perceptions of PWID and the community healthcare workers versus those of the specialists. So for example, this group of specialists, they have some valid concerns about tuberculosis or other opportunistic infections, or the need to screen for different illnesses and so forth. But in general, I think especially among this group, we see that there are some attitudes and biases that come into play that prevent the physicians from giving these people timely access to the medication. So while most of the barriers among the specialists focus on kind of attitudes and perceptions of the patients themselves, I think you can see from the results of the PWID that they perceive that their interactions are making them uncomfortable, that there's stigma, and that the process is just too complex, or they're afraid of being criminalized. So you see that there's a dissonance between the groups that we did this pre-implementation assessment with. So again, these are the top ranked barriers, the ones that receive the most votes. Like in Peru, we also try to map this according to the socio-ecological model, and we see that most of the barriers, the ones that are bolded, are actually the ones that came up as the top ranked barriers. Um, and most of them are like at the interpersonal or organizational level. So that just starts giving you kind of like an idea or a clue of where you need to intervene, where your solutions or interventions need to be focused on. And I should also add that as part of this work, we also did a deeper dive into the solutions that you are welcome to read in our manuscripts. That unfortunately, I don't have time to go through the different solutions and what was proposed by the different stakeholder groups. But in terms of recommendations or outtakes from this discussion, as I was mentioning, there was a high dissonance between the concerns of the PWID and the community healthcare workers and the HIV specialists. And across the board, we see that stigma continues to be a key barrier to same-day ART. And in order to address these different forms of stigma, we recommend various things. One thing that we're doing right now is coming up with a protocol that includes a series of checklists and also scripts that are able to help address rapid start ART and also address stigma. So if providers have kind of like an objective list of like a checklist or like a more objective list of criteria in order to start ART, that's gonna kind of like help address some of these biases or their perceptions about patients' readiness for medication. Similar to Peru, we also recommend optimizing processes. There's a lot of work to be done in this front, especially in regards with confirmatory testing. So these focus groups kind of like helped us identify a lot of the bottlenecks and the barriers that came up to that same day initiation. And now, for example, we are providing like additional rapid test kits because what happened is that many of the sites didn't have like an additional rapid test kit in order to screen for HIV, and they were sending their samples to the lab and waiting for the lab results in order to start someone on ART. But the Malaysian guidelines actually allow physicians to diagnose HIV just with two different kinds of rapid tests. So that's something that we started implementing after doing these focus groups. And then like in Peru as well, we also recommended doing flowcharts and walkthrough in order to kind of like identify many of these persistent bottlenecks and these processes that might be inadvertently or advertently reinforcing stigma among people who inject drugs or other key populations. And like the Peru paper, you are also welcome to read our findings more in detail through this QR that I'm posting here. And then before I quickly jump, we have, I think, like 7 minutes for question. I, of course, wanted to first acknowledge our sponsors and our funders, the National Institute of Health and Fogarty. But most importantly, I also want to acknowledge and thank our wonderful team and colleagues from Peru, who I have here. Many of who are not pictured as well because they recently joined the team or were not involved in this manuscript. So this is my team from Peru, and then of course my team from Malaysia as well. So I just wanted to thank everyone for tuning in and for the opportunity to share my work and my insights on NGTs. And we have a couple minutes of questions, but if there's any other questions or comments that are left unanswered, feel free to email me. So I'll just leave my email here on the screen. And I do see that we have a question from Victor.
Okay. Yeah, David, can you hear me?
Yeah, I can hear you.
Thank you so much for this wonderful presentation. I learned a whole lot listening to you. So I would like to ask another question. Like I already said before, I want to ask a question now, and it's about to what extent did the NGT outcome align with the existing national HIV guidelines in Malaysia? Were there discrepancies, and how did you handle these discrepancies?
Right. So I think the national guidelines in Malaysia are pretty clear in terms of like recommending rapid start initiation. I think the issue is the implementation of the rapid start, right? So I think when we did these focus groups, we found out that there was a lot of different interpretations of the guidelines, or there was not a lot of like clarity, or perhaps there was a lot of misinformation about the guidelines themselves. Because, so for example, as I was mentioning, the issue of the rapid test. So the Malaysian guidelines require you to have a second test confirming that someone has HIV. And the way many like physicians or even healthcare workers interpreted that is, oh, we need to send this to the lab. We need to have a lab-based confirmation of the results, and we need to look at the results in order to start someone on ART. And what happened then is that this just delayed the treatment for days or weeks, or perhaps the patient never showed up to care, so they never received their ART. So I think the focus groups were helpful in kind of like helping us shed light into those moments of misunderstanding or misinformation, but also kind of like reinforced a lot of the of what we knew about the Malaysian context. So, for example, this issue of pill training, which you would expect for it to be an issue perhaps in like a more conservative part of the country or with doctors who don't have much experience with these populations. But interestingly, we found out that these issues are also common in Kuala Lumpur and even in among specialists from like a nationally recognized organization of HIV care, which is the people that we did these focus groups with. So I think the focus groups were helpful in kind of like shedding light to newer issues that we didn't anticipate and kind of like reinforcing certain things that we knew about the context. Yeah.
Thank you, David.
Thank you, Victor.
Do we have any other questions, anyone? Um, well, I have a question, and it's about something you mentioned. Well, something that is not a presentation, but you mentioned it that also uh, you use the nominal group technique to find out the potential solutions as well, right? So, what are the challenges of having those two questions, like doing it in the same session, two separate sessions, different dates, the same group? What are the challenges of doing that and keeping people focused in the barriers that they have identified before?
Yeah, that's a very good question. I think like on average, I would say like when we ask both the questions on barriers and facilitators, the session can go for like an hour and a half, maybe. And I think at that point, people do start getting tired, and maybe at the end of the session, maybe some people don't vote, or like you start getting into kind of like a problematic territory. Sometimes we have found out that like some groups don't have a lot to say about barriers, and they have a lot of ideas about solutions, or vice versa. So it just really depends on the group, and again, it requires kind of like very skilled facilitation in order to help keep everyone engaged. I find that like sometimes when you notice that someone's not speaking or hasn't contributed that much, maybe just like starting with that person or starting the next round of ideas with that person is helpful, just kind of like to elevate their voice. But in general, I think it's helpful to ask them during the same session, even if people get tired, because then people still have kind of like the barriers in mind. And of course, I think in order to like just for kind of like scientific methodological rigor, I think it's just helpful to ask the two questions to the same group of people because then you have kind of like an alignment between the barriers and the solutions. I don't think we have tried to do otherwise.
Mhm. Great, excellent. Excellent presentation, David. Thank you so much. I don't know if we have one more minute, if someone else have a quick question. Mhm. I don't see any hands or anything in the chat. So, thank you so much. Wonderful presentation. Uh, it was great learning about how you have used the technique and about your work. Thank you so much.
Thank you, everyone. Thank you so much for having me and for tuning in. And again, as I mentioned, feel free to email me if there's any other lingering thoughts or you just want to connect.
Great, excellent. Thank you.